The topic is cardiac tamponade. In cardiac tamponade, there is accumulation of fluid in the pericardial space, leading to increase in the intrapericardial pressures, compromising the ventricular function and then decreasing the cardiac output. For fluid to accumulate in this fashion, few factors are important, such as the rate of accumulation of fluid, the volume of fluid accumulating, and the compliance of the pericardium. There might be a situation in which a small amount of fluid can lead to raised interpericardial pressure substantially because it's accumulating rapidly, whereas the more gradual accumulating little larger amount of fluids might not raise the intrapericardial pressure substantially because it can be well tolerated. The patient presents with pulsus paradoxus, narrowed pulse pressures, and hypotension and diminished apical impulse, distant heart sounds, elevation in jugular venous pressure, distension in neck veins, tachypnea, tachycardia, diaphoresis, and the patient may present with dyspnea, lightheadedness, fatigue, and anxiety, abdominal fullness, chest discomfort, slowed sensorium, and shock. Beck's triad associated with this condition is basically a combination of distant heart sounds, hypotension, and increased in jugular venous pressures. The chest X-ray would show cardiomegaly, and ECG would show an electrical alternance, whereas there is a variation in the R wave from beat to beat, and the voltages of the QRS complex is reduced. Most frequently noticed in neoplastic effusions. And then right heart catheterization would show findings wherein the Y descent is blunted or absent and the X descent is preserved. And what's happening is an equalization of the right atrial and the right ventricular pressures in diastole, and because of this the pressure gradient is minimal, and equalization of right atrial, right ventricular diastolic pressures and pulmonary capillary wedge pressures occurs in this. And then in echocardiography one can see a diastolic collapse of the right atrium and ventricles, and then there is a flow velocity paradox where there is a variation with respiration in the Doppler inflow velocities across the valves, such as the mitral and the tricuspid valves. Then the TEE and TTE are utilized, and basically in post cardiac surgery situations there could be the development of effusion at the level of the atria, and basically it could be a loculated effusion, and TEE is pretty helpful in those situations. And then the MRI and the CT can be utilized to look at the location and then to look at the etiology by having some idea of the content of the fluid. And one needs to differentiate at times between the constrictive pericarditis and cardiac tamponade. In cardiac tamponade, the small sign is absent and pulsus paradoxus is present, whereas in constrictive pericarditis, the pulsus paradoxus is absent and the small sign is present. The pericardium is thickened in constrictive pericarditis, whereas it's normal in cardiac tamponade. And right atrial pressure waveforms wise, there is blunted or absent Y descent in cardiac tamponade, but there is a prominent X and Y descent in constrictive pericarditis, and the equalization of end diastolic pressures is seen in both these conditions. Etiologies are many. Some are more common that lead to tamponade, whereas the others don't lead to tamponade commonly. Any cause that cause the pleural effusions, any causes that lead to pericardial effusions and acute pericarditis may lead to cardiac tamponade. Some more commonly lead to tamponade than the others, and since the etiologies are many, some may lead to this condition more acutely, whereas some others may lead to this condition in a subacute or chronic fashion. The ones that lead to tamponade more acutely would be trauma or a dissecting aortic aneurysm or a ventricular wall rupture. Causes could be iatrogenic or post MI, and more subacute and chronic causes could be like the metabolics or the neoplastic or the autoimmune diseases or the infections. The most common etiologies to produce tamponade would be idiopathic. They would produce tamponade more commonly, and then the infections such as the mycobacterial or the other bacterial infections, the virals, including HIV, the fungi, and the neoplastic causes, they would tend to produce tamponade more frequently. And of course, there are other causes also, like the radiation and then the uremia and the autoimmune or the collagen vascular diseases and so on and so forth. And then the drugs also produce certain medicines, drugs produce. There are also an etiology that could lead to this condition, and they would incorporate hydralazine, procainamide, isoniazid, phenytoin, and once again, there are many etiologies that can lead to cardiac tamponade. Therapy-wise, fluid resuscitation, medical therapy-wise, fluid resuscitation, and IV fluids, basically maintaining the filling pressures and maintaining the filling pressures with the help of IV fluid, and then trying to avoid medications that are preload reducing, and then also keeping at the back of mind the fact that sinus tachycardia, basically, which can also be appreciated on the ECG, basically is a compensatory mechanism. It's an effort to maintain cardiac output. Hemodynamic instability is an urgent indication for pericardiocentesis. Basically, there could be a percutaneous pericardiocentesis and an open pericardiocentesis. Percutaneous pericardiocentesis can be performed under echocardiographic or CT guidance, and it's a safe procedure for the removal of effusions, and but in situations where the percutaneous procedure cannot be performed, or there are recurring effusions, or there are loculated effusions, one could go for an open pericardiocentesis, and with the creation of a window, and basically a pericardial window draining into the pleural cavity can be there, and there could be a placement of a percutaneous drainage catheter also, or a pericardial window draining into the pleural cavity. And then biopsy also helps in establishing the diagnosis, and that can be obtained as well.